Evening and welcome to all. In today's session, we are going to focus on a very important topic, and that is how to set up a palliative care clinic. And we all agree that a good palliative care can do wonders in improving patient care by reducing the symptom burden. And if pursued with passion and dedication, it is very satisfying a job. But as young enthusiastic MD and DNB palliative medicine postgraduate students join the brigade of palliative medicine experts, it is of utmost importance for them to sustain their passion in the field by making the services sustainable, cost effective, and non exhausting. Today, we shall be hearing from our experts who have been successfully working in different setups like government setup, corporate setup, or a charitable setup and have been successful in delivering good palliative care. So, the chairpersons for our session are Dr. Maya Mascarenas from Bangalore and Dr. Suresh Kumar from Calicut, Kerala. Dr. Maya is the external consultant of NHRSC and the National Task Force member for Ministry of Health and Community Processes in Health. She is an alumnus of Bangalore, St. John's, Bangalore, and holds a PhD in Human Development from Texas University, USA. And she's also a DNB in palliative care. I welcome you, madam. And our next chair is Dr. Suresh Kumar, who's the director of WHO Collaborating Center for Community Participation in Palliative Care and Long-Term Care. And Sir is also a technical advisor of the Institute of Palliative Medicine in Calicut. I welcome you, sir, and I hand over the mic to our chairpersons to introduce the speakers.
Thank you, Nimisha, and good evening, everyone, and welcome to this session. And I'm really pleased that we are having such a session because I think palliative care now has to come to the forefront. We've really there's such a huge need, and when we know palliative care is probably the closest to family medicine, and it cuts across and spans across so many different specialities, and a huge need because the burden of suffering is just increasing day by day. And I'm very proud to introduce the speakers to you. Shall I introduce them one by one? So we have 3 speakers for the evening, and I'm going to ask Dr. Suresh Kumar, who knows them personally, to also, kind of put in his own personal remarks. And we start with none other than Dr. Malika Thiruvadanan. And I'm just going to share my screen, which will give you a short kind of summary of like a bio sketch. I mean, it's very small. So she's been a specialist in palliative medicine for over 2 decades and has been working largely in Tamil Nadu, and currently is based over there with both the Madras School of Social Work and Sundaram Foundation, and also has been a national faculty with IAPCON. Her areas of interest are training, and it cuts across all cadres of the healthcare force. And I'm sure she's going to be a very big asset to the state department and their program in palliative care. We do know that the government has launched the national program for healthcare of elderly and palliative care. And so every state is going to have its own program, and I'm sure Dr. Malika is very actively involved in that. There are a large set of achievements that she holds, and some of the landmarks are that she's helped the state get the amended narcotic rules implemented. She's been a resource person for the WHO, and she's been an adjunct professor with the MGR University, and she's been honored by the Rotary Club, by the NHM, and also called. So I'm going to ask Suresh to add a few words of introduction, and then he will hand over to Dr. Malika for her talk. Yes, Dr.
Okay, actually all the 3 speakers pioneers in the field of palliative care in India, and what we can. Maliga, I think Maliga is the senior most among the three. Maliga started long time back in Chennai. Yeah, I had known her from that time. Actually, the advantage in having these experienced people or pioneers is that they will be able to tell you the how it began and how what are the problems that they face now, and compare it with the situation now, so that people was willing to initiate or modify will be uh, really benefiting from the both the experience, and it's not just the theory that they'll be. I think that's what I understand. Amelia has been with the Lashmi Palliative Care for a long time, quite long time actually. I think it was the first hospital-based palliative care service started in Chennai. Yeah, happy to see, and let's all listen to her and sort of see what she brings in. Happy to see you, Maliga. Yeah, over to you.
Thank you, Dr. Suresh. Very good evening, everyone. First thank to Anjum and the organizing committee and the IAPC for having given me this opportunity to share my experience in this part of the practice in palliative care from our state. And I think can I share the screen, or should we, is it the recording? Is it possible to share the screen?
I think they're going to go
I
into a
think
recorded
so.
version, Nimisha. Just correct me if I'm wrong, but I think she's frozen. But the tech team, are you going to just shift to the recorded version?
Good evening, everybody. I'm very happy to be able to participate today in this conference, and I'm very happy to share my experience about this setting up of practice of palliative care in this model. I thank Dr. Anjum and her committee and the IAPC for having given me this opportunity. And let me also say that I have to put in my words of gratitude for my mentors who have taught me initially and then motivated me and imbibed all the passion that I have today for palliative care. So today we'll be talking about this particular type of model. Okay, the other models, the other speakers will talk to you about. So I'm going to be telling you basically about this hospital-based charitable organization. So those of you who are wanting to do this or practice in this manner, then I'm sharing my personal experience, how we started and how we went about, and it will be helpful to you. So I'm going to talk to you about it on these lines. That is about having clear objectives, the goals, using the right terms, what do you need when you start, and of course, our attitude and how we get the finances. This is the hospital where we work. And this is actually the space that is given to us in one of the floors, half the floor is where we practice. Okay, how did we actually start? Now, we had very clear objectives. So what we wanted to do basically was, of course, give the quality palliative care to patients. And I would say that our main focus should be on the patient, not about how the name of the hospital should get blown up, but just the focus on the patient. And we must always see that we reduce the financial burden for patients. That was the whole idea of starting it on a charitable basis. And we had very clear objective about educating and training healthcare professionals. I've been very keen on this, and because of this keenness, we also have to do side-by-side public awareness. And our vision actually is to develop palliative care in the entire state. But then not everybody need to have these objectives also. It is okay if you just have this and later on maybe add this. So this is how we started. And if it's a charitable trust, definitely you need to register it and have your statements regarding the trust. Then, of course, the goals. So realistically, how can you really start? Okay, so it's whatever space that is available there in the hospital, or what they give you, just start off start off practicing, just like any other doctor would start practice, whatever place you have, just start the practice. You don't need a separate kind of a thing, but if there is a room available, then take it. Then you start just telling everybody about it, your friends, your colleagues, other specialists. And definitely, nowadays, you should say that, palliative care is very beneficial for COVID patients also. The difficult, distressing physical symptoms, the psychological issues. You could even help over the WhatsApp calls, etc. And then start make visiting cards, inform friends, colleagues, all those whom you can get in touch with, those whom you know. And probably a little later, you can increase your advocacy by, making your leaflets. And when doctors refer patients to you, make sure you reply them. You reply them and tell them what you're doing. So it's one way of educating them also. And, they can send you more patients and start getting involved in the educational and awareness programs. And long-term goal, as I said, if you wish to develop the care in wherever you are, the village, the town, the state, and then you can start doing that also. Okay. So before you do anything, we must understand that we convey the right message to the public and to our colleagues. I mean, colleagues, we do it in an indirect way because we are mostly interacting with our patients, okay, and then the public also. So we must make sure that they get this message that it is an approach. It is not just for terminal care, terminally ill patients, or dying patients. So let's not use these words straight away. We must be very clear that palliative care is definitely there from the beginning to the end of a disease trajectory, and it's a need-based one. So send these messages across. And the supportive care, the term, even MD Anderson in US has changed it. So adopt these correct terms. Otherwise, we'll be getting references only in the very, very late stage, and we will not be able to even help patients to our best. Okay, so use the right terms, and with these terms, go about making your leaflets. These are our earlier ones. And, put in your objectives, put in the facilities, the services, the charitable things that you're doing. All these things will come in a very brief manner. Okay, and these are our, of course, you can modify them. These are our present ones, and our logo stood clear from the beginning. And I was very sure we wanted to show the doctor part of it. It's not just holding hands. So there is a medical treatment for physical symptoms. So all these things you can start putting your leaf. So when we started just with the outpatient care, and then we went on to inpatient care, and you can use any room in the hospital. No need for any like separate palliative care ward or palliative care rooms. They're also part of the hospital patients. So just admit them in whatever budget they want, wherever they want to be as inpatient. And then we went on to do the home care. Okay, so this is how we kept expanding our facilities. And what do we need? What do we need to start with? Really not much at all. See, again, this is where we started. Okay, this is our old hospital, and we just took one room which is already there. In fact, it's a big room, so we partitioned it and made use of it for consultation. And then you need some space for patients to wait, and then try to train one of the hospital nurses itself, unless of course you get a trained nurse, and then do it hands-on. Later you can send them for training. You need to have a morphine locker when you get your morphine after you get the license and all that. So that I think somebody will be talking to you about it. And then you have this usual stock cupboard for medicines when you have to give it free of charge for poorer patients, those who can't afford. And then, of course, it's good to have another room or enclosure where patients might have to wait there for a longer time, with IV fluids or ascitic tap or lymphedema care, etc. So basically the equipment's the same, the BP apparatus or the dressing tray, etc. Maybe later you can get a machine for the lymphedema care. So that can also be accommodated. So the other thing is, I put it there as emotional requirements. Okay, so have the self-confidence, keep reading, updating, keep that pharmacopoeia book with you, keep your maybe the IAPC manual with you. Call anybody for help, those who are experienced in this, your colleagues, your seniors, anyone when you need them. And of course, there will continue to be colleagues, senior people who may not think much of what you're doing or about palliative care itself. Just keep a neutral attitude towards them, no judgments, apply whatever we learn in communication skills to our own selves, okay? And try to involve the hospital staff, hospital nurses, because they are going to be there throughout where you practice. So they will also get involved and they will be there to help you out, even when our, the specific palliative nurses are not there. And then, of course, you may not get many patients in the beginning when you start. It's quite natural, but just maintain hope. We tell our patients, no, to maintain hope. So same way, let us maintain hope and never give up. And then, of course, the finance. Now, this is very important, isn't it? So many of you ask, how are we going to get our finances? So one thing I must be very clear about, that you should also be clear about, is when you do your work well, committedly, with compassion and competence, treat the physical symptoms very well, half the emotional problems will go down, and then, of course, the compassion. So when you don't charge and you do your work very well, you will get several times more than you get for your consultation fees. So we have seen these things. They just donate, those who can afford. And the families, they continue to donate, even after the patients pass away, and they become regular donors, monthly, yearly donors, like that. Then, of course, keep doing your advocacy with, all the social media things. And so make use of those. Make use of accept any invitation that comes to you. Come and talk in our club. Yes. So come and talk in our association. So accept these and keep giving your leaflets and donation slips to them. Carry them with you wherever you go. Our volunteers carry them in the auto when they travel, everything. And we also do that. And then organize, of course, start organizing now public awareness programs and fundraisers. And build a team with good volunteers when they want to join. Just make use of them. They will also help in raising funds for us. So just word about public awareness programs. So start writing articles. This we started doing way back in 2000 itself, and then in your local language. So all this can be done. Keep doing this side by side. When they, radio talks, make the volunteers go to public places and help out. And you can also choose these days, special days, no? World Hospice Palliative Care Day, or make it an annual day when you started your trust. So 2 or 3 days in the year, make use of them to again spread awareness, put posters, use both local and English language. So these are some of our awareness programs which we've been doing continuously from then. And volunteers play a big role. They help out in, as I said, and this you can see, even our family members are there. And the clinic team is there. So everybody joins hands when we do all this for a cause. And then, of course, do a few programs in the hospital itself, even the training program, CME also you can do. So that all the others will get to know your colleagues, your other specialists. And that is very good for the hospital, where they can start integrating also. And once you do all this, you're really recognized for your work, and they simply call you and they give you the donations. This car vehicle we got as a donation for home visits. And so you can see how you can benefit by simply doing your work well. And then we also had the opportunity to work in GH in our own government hospital for a year, and we were recognized for the same. So about the fundraisers, don't think that every year we have to do these. Not like that. Whatever is possible for you. In all these 20 years, we must have done about 5 or 6. But the donations kept coming through the years, even during COVID times. Thank God for that. And if you're doing it every year, try to do it in a specific time of the year so that people will anticipate and be ready for it. Involve every others also, because it is not very easy to do all by yourself. You need help. And one thing I want to stress here is, it's not just about the tickets that will get you the money, but if you write the letters at this time, make use of this time to write letters where you need, much bigger amounts. Say 1 lakh for a year we are spending for morphine, or 5 lakhs per year we are sending for this. So bring out letters like that with the breakup details. And then these are examples of what few programs that we did. So if your long-term goal is again now to develop palliative care, you need all the 3. In Tamil Nadu, in our state, and few other states, definitely, This is all in place, no problem at all. But education, I know throughout our country, we need to keep on educating existing professionals till it comes into the medical MBBS curriculum, which I think will not be far off. But keep doing that. So if this is a goal, then you have to get involved in all these CMEs with the universities, other government institutions, approach the government, the departments of health and other administrators and ask for help. Dr. Rajgopal sir used to come for our initial programs and help us out. And we have our own society now, the Tamil Nadu Palliative Care Society. Dr. Republica is also part of it. And so you can do all those things. So this is what I was saying, just the picture is document for that. Different programs in different medical colleges and hospitals and universities. And recently we've been with the National Health Mission. So they came up and Dr. Rajgopal sir put us on to them. So we've been doing this training from 2017. So we give the knowledge to them, we train them, and they have the finances to start palliative care centers in all the 32 districts. They have started with training these doctors. So we can really reach out to the community through the government. So if we want to really develop in our state, then we can go through that. And to summarize what I said, this is a hospital-based charitable organization. So whatever the model is, focus on the patient. Automatically, the institution name will boost up. Then have very clear objectives of what you want to do. Have a good attitude throughout. Don't give up, and have a neutral, outlook towards whoever it is. Set goals and then work towards them. And of course, with the advocacy, keep on carrying it on, and you'll get financially sustainable. And definitely, you will enjoy the fruits of your efforts. And so, to conclude, I would say that we have taken up this learning, this new learning, which we never learned at all, and we know how much it affects the society and how much it helps them by improving the quality of life. And therefore, we have to give that to the society. So believe in yourself, you are there to help patients with your knowledge, skills, and attitude. You have to give that to society. I'm very thankful for our teams here. And thank you all very much, the IAPC and the entire palliative care community. And we are there to help you anytime, can contact us at any time. Thank you so much.
Thank you so much, Dr. Malika. Do you want to add anything live now to what you said? Just a few seconds.
First of all, because I didn't know Dr. Suresh Kumar was going to be one of our chairpersons. So I'd like to thank him also. He was also one of my mentors in IPM. And thank you, Dr. Mai, for your introduction also about me. So the other thing, nothing particular, unless I thought if it comes up in the question answers. So yeah, nothing particular that I want to add.
We will have the question and answers a little later when all the three speakers are done. But I just want to say a few points now, or maybe we just do that at the end. I'll leave it for the end. But thank you very much, Dr. Malika, for introducing the idea of palliative care in a hospital setting and the importance of, the steps that you take to achieve a long-term goal. We're going to go to our next speaker, and I'm even more excited to introduce her because I know her, and that's Dr. Savita Butola. And it's very fascinating. The first time I got to meet her, I think online, because she's with the Border Security Force, and then automatically you see this lady in this uniform, and then you see the other very humane aspect of a very, very kind looking and very well, very experienced physician. And it's just a beautiful blend, because you always think the military are so aloof and different. So very happy to introduce Dr. Savita, and she's, like I said, with the Border Security Force. and currently she's the commandant, the chief medical officer in Tripura. And having studied in Amritsar and done her palliative medicine in the UK, she has several years of working in the palliative care section, and especially in the forces. And she also has been very active with IAPC and has been the honorary secretary of the IAPC for a long time. And she's the founding member of eHospice India, and they launched the first online bereavement support website, which is something that will really help a lot of people. And like Dr. Malika said, we should not forget COVID, because that's something that's hitting everyone worldwide today. She's also had several publications and awards, and I'm very happy to introduce you, Dr. Savita. And Suresh, Dr. Suresh, would you like to say something about Dr. Savita?
Yeah, like I think the both of them, both Malika and Savita, they started palliative care in a hospital setup, but there's some difference. Like Malika started in her own a small private hospital, and she was the decision maker. But so what's more important about Savita is that even before palliative care was established in any of the civil society hospitals, she managed to start one in a uniform service hospital. That's important. And also, bigger hospital generally will mean more help, but bigger hospital will generally mean more resistance also for a new concept. So this is something that I'd like to hear from Savita, because complicated setup, more bureaucracy. Let's see how she managed to do it.
So Dr. Savita is going to take us through how to set up a palliative care program in a government or a quasi-government setting. So over to you, Dr. Savita.
Please. Good evening, ladies and gentlemen. I am Dr. Savita Putola with the Border Security Force, presently posted in Tripura, and I shall be talking about setting up of palliative care services in the government sector. Before setting up any kind of service, it's very important to understand the kind of setup that one is going to work in, whether it's a government, private, NGO, trust, or society. What is the level of care that will be provided? What is the profile of patients who will be coming? Where in India is the service going to be located? Because the states in which we are present will determine the level of education, awareness, training, whether it's rural or urban. That determines the access, transport, ratio of staff to patient, and the local culture, which affects the public involvement as well as funding and voluntary support. There are many models of palliative care. A hospital palliative care unit has indoor beds of its own, specially trained staff. This allows better control of symptoms, and it's suited for secondary as well as tertiary level care. It gives a good teaching opportunity, but it's expensive to set up as it needs space as well as equipment and specially trained staff. It can also be in the form of a hospital palliative care advisory team, which does not require any beds, space, or equipment, but it does need backup if admission is needed. And it is the best model to use if resources are limited or needs of the institution are less. But the issues are that there is lack of control over the symptoms and the medication use, especially if other people are not palliative care oriented. And this is only advisory in nature. It does not admit patients in its own unit. A daycare unit can be there. This is also another easy, inexpensive model to set up. Usually it runs with the help of volunteers who bring in the patients from 10 to 3 o'clock during the daytime. It gives families some respite from their exhaustion, and it is helpful for patients who have been wanting to do something productive for a long time. It allows them to indulge in their hobbies, in recreation as well as social interaction. Besides getting they can get medical care and support. They can get entertained. They usually have some activities followed by lunch, and then by 3 o'clock, they are taken back home. Another model that can happen is a community care model, where there may be a mobile clinic which visits the patients at home once in a week, twice in a week, or once in a fortnight. There can be an advisory team which looks after the patients only in a support capacity, and the primary care doctor and physician, nurses are basically responsible, but this team only advises the main physician for palliative care.
The community care can also be provided by a comprehensive care team, which is more trained. It also allows the patients to stay at home longer because these teams are trained to give ascitic taps as well as basic chemotherapy as physiotherapy at home. But when one is starting services and there may not be availability of a full team or doctors, one can start with a nurse-led team. This should be thought of only as a stopgap arrangement. Nurses can be easier to find, but there are many things which are beyond the expertise of nurses and require a doctor or a specially trained team. So this can be very stressful for the nurse who's working alone and should not be a long-term thing. The last but not the least, hospice, as we are all aware, but one needs to think of who are the patients, where they will come from. Is it only for end of life care, or is it going to be for symptom control also, and the patients will be discharged back to their hospitals or homes? And the important thing for a hospice is how to avoid that association with death and end of life care. This is a slide which shows the care factors and the different kinds of models which are best associated with them. When we talk about the government sector, it is important to talk about the strengths as well as the weaknesses. The strengths of the government sector are that it has access to the most remote places, the poorest people. The district hospitals, CHC, subsidiary centers, and ASHAs can help reach and identify the remote areas, the rural poor. One doesn't have to worry about the salary, budget, and hiring because it's all a given. The diagnostic facilities, physiotherapy, rehabilitation are all inbuilt. And the government medical and nursing colleges in India are the hub of medical education as well as change. But there are many weaknesses. Mainly, they are all understaffed. There's lack of sufficient budget at all levels. One cannot select their own team. And because of the large number of patients, the staff faces shortage of time. There is a poor image in the minds of the public. Any change that you want gets mired up in the red tape. And the staff is usually expected to do palliative care work besides their own general work. This is quite impossible to do. It doesn't help either group of patients and results in poor quality of palliative care. Another problem is that the government sector hospitals are supposed to buy their stores from government medical store depots, and these do not list opioids in their list of medicines. And since I worked in the armed forces, a little bit about the armed forces also. The armed forces have a lack of awareness and trained staff and lack of opioids for even gunshot and blast injuries. You can imagine the amount of unrelieved pain that our soldiers have. The way of working has an inherent resistance to change. Decision making is all centralized and there's very little scope for changing at the field level. The whole team moves away every 2 to 3 years and disintegrates. So every time you get a center recognized, it needs a new RMP. And then what happens to the opioids that a center has after the doctor moves away? Priority for armed forces is always operational commitment, and they often remain isolated from the national programs as well as the trainings organized by the state government. When we need to send our serving personnel home, it becomes difficult because of lack of palliative care in those areas. Networking therefore becomes very important, and WhatsApp groups, social media, and list of state directories which are listed on websites are very important for us to look into when we have to send our patients home. The patients have their own set of problems. The stressful life nature of work, which is worsened by chronic illness and loneliness because they stay away without their families for long times. And in remote areas without access to tertiary care, there's a lack of stability in life, temporary duties, internal security, election duties. This results in lack of continuity and consistency of care. Patients who are on opioids at one place may not be able to access opioids when they get posted out to another place. They cannot be with their dying family members very often, and it is stressful for families also who are away from them. It is the unit personnel who take care of the sick unit members even during their death, and families are not available for face-to-face discussion, advanced care planning, and so looking after their socio-cultural needs and religious issues becomes difficult without their families being present. This often results in complicated grief and bereavement for the serving personnel as well as their families. But there are good things also. They have a well-defined population, a very good disciplined work culture, meticulous documentation, even in case the records are held by the patients. And if one can convince the top brass, implementation follows automatically. Within the campuses, home care is very easy. Rehabilitation, psychosocial, religious, financial, and bereavement support is all inbuilt into the armed forces systems. They have a lovely communication network. Telemedicine is possible even for remote areas. Consultation for civilians is also possible. We have special budget for that also. Whenever staff is posted out to new areas, they still carry their knowledge with them and help new patients. And if we can get this included in the entry-level training, every new healthcare worker who comes into the armed forces is automatically trained and oriented. And since armed forces are part of national disaster response teams, they can help in humanitarian situations also. So when you are planning a service, it is good to do the spade work first, and that prevents ending up with a service which is not suitable for local needs. Have preliminary discussions with local health authorities, national health authorities. Look up palliative care websites for what documents you will require for certification, licensing, legal requirements. Visit other services, see what is good, and try not to replicate, but to convert that model to your local needs. Have a detailed financial analysis done. You will need to know the cost, capital needs, sources of income, whether it's possible to share facilities of procurement of medication and equipment. Usually in the government sector, this is not possible. You need to look at cost of education training as well as staffing. Do a basic needs assessment for the patients, the kinds of patients, number, age, sex, the causes of death, symptoms, emergencies, and number of deaths at home that have been occurring in the last 3 to 5 years. Have preliminary discussion with your administration, convince them that this service is going to be needed and that it will reduce costs, it will fit into the existing setup. Take them for visit to other services, show them the data from other setups, try to organize CMEs with senior palliative care physicians and nurses, and talk with all the other healthcare providers in your area who may be affected, especially the non-oncological specialties who have a huge area of patients to look after. Talk to patients, families, community volunteers, policymakers, the local political representatives. Talk to pharma companies who can help support education and training, and also talk to corporates who can help us with the funding. When planning, it's important to prioritize the work, whether it is going to be advisory, home care, managing active patients, or education. How will the relationship with other services and medical community be? Also have a palliative advisory committee consisting of external experts who can advise and support us. A subcommittee for education and research, because the caliber of the senior external experts in the committee raises the profile as well as the credibility and authority of your service. Whenever you are planning, plan for at least 5 years, because it helps to set goals and gives direction, priorities, and helps in resource planning. The staff and the volunteers must clearly know what is expected. There must be clear written duties, SOPs, protocols, clear lines of communication and accountability. Ethical guidelines must be written down in newsletters, notices, and handbooks. And when you're planning for finances, it's important to remember that though less costly, palliative care still needs money. And it's a good idea to plan for budget requirements just less than 10% of the current local acute units. The funds in the government sector normally come from the National Palliative Care Program, but for children, you can take help of ICDS scheme. For elderly care, you can take help from HelpAge India as well as the Elderly Care Program. And CSR funds can be used for home care. This is allowed under the National Palliative Care Program. A little bit about the National Palliative Care Program. Sorry. This is a centrally sponsored scheme, and it's part of the National Health Mission. So under the model PIP, which is part of Mission Flexipool, the states and unit territories can ask for budgets for districts as well as the state level. For district hospitals, the budget given is 48.4 lakhs, and this includes non-recurring infrastructure strengthening expenditure up to 15 lakh rupees, money for a physician, 4 nurses, 1 multitask health worker, as well as for training and miscellaneous funds. For state palliative care cell, the money is about 10 lakh rupees a year with 1 data entry operator, 1 coordinator, and miscellaneous expenditure up to 1 lakh a year. When one is trying to build up a team, have a multidisciplinary team in mind, get them trained, look at other disciplines who can support, look at transport, mortuary, funeral services, where will postmortems happen if required, select people with aptitude and empathy rather than looking at only training. When training, focus on skill development. There should be no learning on the job. And for your teams, arrange social interaction with picnics, movies, and dinners. For that, we'll have to wait a little bit till COVID gets over. And for units, aim for a high patient to nurse ratio. At least 50% of nurses on duty at any time should be trained in palliative care, and same goes for nurse auxiliaries. And remember that most experienced units do not use student nurses for duties. The number of doctors requires looking at the number of beds, number of junior doctors available, emergency cover which is required. Usually a full-time doctor can look after 10 to 15 indoor beds, 40 patients in the community, advisory work in daycare unit, and give up to 3 hours a week for education. If there are 15 or more beds, you will also need physiotherapy and a post-pastoral guide who have to be full-time if there are more than 30 beds. The training of the staff, pre-induction can be different from 3 days to for some weeks. In-service training is required every 6 to 8 months for updating their knowledge. Advanced training for patient handling, counseling, teaching is required for people who are required. For volunteers, there are different training programs required. And documentation, there's a list of documents which may be needed, policies, SOPs, indoor charts, outdoor charts. And it's a good idea to include pain score and vital charts. It helps to increase the coverage. There are many softwares and apps available which you can look at, and also look at the retention period of the records, legal advice, clinical audit documents should be maintained from the start. Visiting guidelines, if different from other areas, may seem unfair. Children and pets are being increasingly allowed in different units. And obtaining opioids, we have a whole session on this, but it's important to talk to the administration as well as drug controller office before you apply. Visit them officially, socially, get a good rapport, organize a workshop, and see the list of approved companies after you obtain your permission. If you are stuck, ask for help. You can look at essential packages which are available for medicines, equipment, as well as human resources. Always plan for educational activities and coordinate with local palliative care faculty for skill development. Others can help you with the theory, but strive to change attitudes rather than teaching them facts. Before launching, circulate details, give out notices. Hospital switchboard and registration, junior medical staff should be involved. Have a final risk rehearsal with realistic pictures and look for weaknesses. Inform the fire, police, and ambulance department services. Organize a reception, invite people from the community, invite the media, allow photography, give a press pack for everyone. Use the media to create awareness, highlight the problems, invite them for all major events. And do remember to see the draft, because media can often change what you have said or take it out of context. Issue press releases about important things. Politicians hold the key to policies and funds, so invite them for private visits, show them around, send invitations, and send regular updates. And in the early dates, you may make mistakes, but learn from them and move on. So finally, some lessons that I have learned from the 20 years of experience is that a satisfied patient and family are the best messenger for your service. Don't lose any opportunity to talk about your service and work, even at birthdays and parties. If there are 100 people you talk to, there will be one person who understands and is dedicated. Don't let them go. When you can't climb over the wall of obstacles, learn to walk around it. It is the team which always wins. And even if you are alone, stand up for what you believe in. For those in government service, it's very important to learn to take criticism, otherwise nothing will ever get done. And if you are inspired, others will also get inspired. Learn to be patient, learn to stick with what you are doing. Look for opportunities, and sometimes you will have to use the stealth weapon of malignant invasion. But remember that even one person can make a difference to the lives of those you are looking after. And never doubt that a small group of thoughtful people can change the world. It's the only thing that ever has. Thank you very much.
non-military part of Dr. Savita that you saw towards the end, and I think that was such an apt ending to extremely clear and detailed session on how to set up things. Dr. Savita, you want to add anything at this point?
No, Dr. Maya, I think we will let people ask questions and then we'll take them after Dr. Republic asks.
Dr. Suresh, you want to say anything?
Not at this, because we are running, basically because I have a few things to suggest, but then we are running out of time, because we maybe will wait till Republica finishes and then I think that'll be better.
So let's go to Dr. Republica now, and she may be the last speaker for the evening, but that does not mean she's any less experienced. And like Dr. Malika, Dr. Republica is also based in Tamil Nadu, and she's the founding and managing trustee of RMD Pain and Palliative Care, has over almost 3 decades of experience in both family medicine and palliative care, and she is now associated with different organizations. She's also on the panel of the Tamil Nadu Palliative Care Society. And her area of interest is actual care, so pain management, palliative care for elderly, and looks at both end of life and emotional and mental health care for them. She's also had several achievements and awards, and as you can see on the slide, and I'm going to go straight away to avoid wasting any time to Dr. Republica. Over to you.
So I'm Dr. Republica Sridhar, founder of RMD Pain Palliative Care Trust. And today here, the topic given to me is starting up of palliative care services. So it's a wonderful topic, because all of us, when we get trained, we get lost what to do, and what are the various ways we can network and start off the services. And this is such a compassionate and I think it's a passion for all of us who get into palliative care. So we really want to help the more people at the earliest. So as we are all aware, it involves the various stages, early prevention, and right from early identification of symptoms, various assessments which is required, management of symptoms, and holistic approach. So we should all be aware that, these are the different stages, and every stage, the facilities might change as and when it is required. So the scope of services, all of us know that we can do it as a home-based care, we can do it as a hospice-based care, it can be a hospital-based care. An institution can have an integrated hospital, or you can have your own private hospital and things like that. And obviously community-based, where we can reach out to the community and look after people. Palliative care model can be looked at in various levels, like you look at, as an NGO model, as a private model, or a corporate model. What do I mean by these differences is, NGO means it's a non-governmental. That is, you give your services, but you don't want to charge for it, or it could be sustaining. We just get donations, which is, taken back into the organization. That can again depend as a home care or a hospice, or even a hospital can be a charity hospital, which can be, so whatever income comes goes back to the organization. That's what an NGO perfectly means. The new thing which we all have to be sensitive about is CSR, which is corporate social responsibility. Many of us are not aware of it. So many corporates can take up our projects and they can run it for us. So in terms of private, you can have your own private hospital or a private home care setup. Maybe a nursing home based care. You might have a nursing home or approach a nursing home and integrate these services. Corporate is completely different, because they have shares and all that stuff. So they look at much more, they have investors, so they look at profits. So that can again be a different model as hospital, assisted living, or hospice. So many corporates have come up with these models, which have been showing a lot of profits and money making kind of a thing, especially elder care services. You must have all be aware of it. So whom do I look at as stakeholders is one question you can ask. Okay, I am looking at starting this services, but whom can I approach? So stakeholders will obviously be doctors, various philanthropists when it is an NGO. The other aspects would be, policy makers, governments, various, training places where importance of palliative care is known. Then networking is very important. Whether you network with corporate, government or non-government organization. Also look at the beneficiaries. Who could be the beneficiaries? Whether you're doing only a cancer model, whether you're doing a non-cancer model, whether it is a neurological aspect. What are the different aspects is what we'll have to definitely look into the whole thing. Then in terms of policy, which is very important, each organization can have its own policy, and based on that, we can look after it. So coming to the various licenses, which is very important. Nobody thinks of this when we start the services. We should also see that, look at what are the important things in terms of starting off the services. So first main thing would be licenses. And now the governments, after COVID, they become very strict. So I want all of us to be sensitive about these simple licenses, which needs to be as a start off. If you're in a big hospital, already they will have all this. So there is no issue. But when you're going to start an elderly service or a palliative service or an integrated service, these are the few licenses which you need to think. Of course, I'm going to share it. So Clinical Establishment Act, because we are prescribing medicines, we should be sensitive about it. Biomedical waste, which has become a very, very important aspect. The Social Welfare Board registration is for hospice. When you're running a hospice or an elder care or a rehabilitation, especially if you're non-profit, see that you do a social welfare board. Fire pollution, sanitary license. Of course, the narcotic drug license, all of us are aware, with the registered medical institution aspect, which is very important. When you start a project, people, when they approach you, they will say, okay, doctor, how much will it cost? And we doctors always find it very challenging to give that answer. Now, first of all, my whole idea today is to say that don't feel guilty when you ask for money wherever it is, even if it is from the patient or when it is, because nothing comes just like that. Because even if we want to do our clinical services free because we're passionate about it, let us understand the manpower people who are there will always require some kind of a thing. So focusing on this, we'll have to divide the budget into a capital cost and an operational cost. Capital is when I want to start off, these are the basic things which is needed, the basic licenses, the infrastructure in place, equipments, what is required, how do the building look or how does that area look, whether we are going to give nutritious food inside or not, whether we are going to have a vehicle which picks up the patients and comes back, then we have to invest on that. Other maintenance cost which goes along with transportation has to be planned earlier. And operational cost obviously will be the trained nurses or paramedical people. It could be physiotherapists, rehabilitative therapists. Then the software, that is very important because data is very, very important. So medical information system should be in place. EB and biomedical waste and all those transportations are all the operational cost. When I mean manpower, it's all the salaries and things like that. These are all the recurrent costs. And of course, we have medicines, which I've not brought up, which obviously medicine lab are all the operational cost, which would be taken up by the organization or outsourced. It all totally depends on how you want to do it. Always remember the project when you start will have, different phases. Today, I start this project. I cannot expect immediately patients or revenue to outflow it. So we have to take at least 0 to 3 years and 3 to 5 years. This is the way we have to look at it. So 0 to 3 years is, first year will be to network, get everything in place. Third year, you will start getting, a break even. Whatever I spend, I can manage the whole thing. So fifth year is the one where you can start getting money out of it. So if it is a non-profit, you take that money and put it back into the project. If it is a profitable or a corporate, you make that look like a profit. Or you tell that this is the income out of, we call it EBITDA. That is after the expenditure and also income tax, what comes in your hand is called the EBITDA. So first time we have to initiate the infrastructure and all that. The next will be capacity building and patient care. What do I mean by capacity building? Not only the building and other things, but also the medical development with that, how we are going to increase the manpower, increase the beds and other things, and how we are going to do the patient care. The third phase will be if you want to take it to the next level, have accreditations, have networking, want to increase your training capacity, make it as a unique referral center or a research foundation. Completely that depends upon that. And based on this, so the day one in phase one, you should think of phase 3. So if you go and ask people to even support you as a non-profit or even in a corporate, they will ask what is your short-term goal and long-term goal. You should be in a position to answer that. So immediately I want this. Over a period of a year or something, this is what I want and this is what I visualize. So this all goes with the vision and mission statement of your organization and your organization structure, how you want to proceed further with your clinical services. So why we have to look at sustainability? Now, this is very, very, very important. And one is, of course, medical profession always has insurance supporting and all that. But as we all know that palliative care is still not reached that stage, except for few states taking up palliative care. This becomes a very difficult situation for patients also. How do we, reach out to what kind of a services? So always we have to put the costing in per day, per bed cost, and the recurrent expenditure which goes with that. So if I break down to that minute, then we will know what is my outcome of the cost. So if my center has 5 beds, then work out accordingly, 10 beds accordingly. Then how do I look at the department? How many multi-level of specialists am I going to involve and things like that. So for the non-profit, we have to understand capital cost so much, running cost so much. How am I going to overcome that? So your target volume of money should be working towards that sort of donations or how people are going to support towards the project, or you can even approach a CSR. Now, cross subsidy is another aspect which you have to see. What do I mean by that? You can have one model which makes money, and that extra money can be used for the other model, which is for poor people. So that would be a cross subsidy model, which you can have it within your own department. So you can tell your corporate people, sir, you can always have, 10 beds which is making money. Give me 2 beds which is for poor patients, which your foundation or someone can support. So that is very much possible. So we never look at those things. So we can categorize our patients which are very affluent or whatever. So cross subsidy and cross sectional patients can be looked at. Always look at the procedures as an extra money as a base of income. We never look at that. Okay, so lab, pharmacy, transport certificate, you can make it chargeable so that your project per se becomes sustainable. Always understand these things are added values, and especially if you involve, anesthetists or other pain medication people or any other aspects, super specialists, then those things are extra added value. Added value services can always be charged. So remember that. Always look at your organization in these are called SWOT analysis. Would look what is the strength of palliative care and your service. It involves comfort care. It involves, a very effective faculty. It is a very cost-effective model, unlike the other models, because there we are going to involve, we'll keep focusing at care. Much of resources are used, whereas here it is not. It is a holistic wellness. It is a mind and body wellness. There is a good feel in palliative care, which is not available in other services. Then what is the weakness of the project? There might be a stigma. The death rate might be more. Then you'll have to talk to the organization. See, I'm starting palliative care. Are you willing to take up this debt? Then if not, then what to do? These are the discussions which you have. And always understand that there is a lot of opportunity in palliative care because you're continuously going to network with multiple specialists. You are going to have long-term care, rehabilitation care. These projects are always, you have to look at, making money and sustaining, and eventually it becomes profitable because of the value-added services. The other threat from is non-acceptance within the medical fraternity itself. You might have hindrance within the organization. Manpower might be coming, going, not permanent manpower. Then ethics is a big problem, and manpower needs to be trained constantly. Every time some 10 people come, we establish everything, make them good, compassionate, scientific person, and suddenly these people are put in some other department. Then these are the threats which always is there when you're developing a department or a completely managing a facility. So the sustainable models, as I told, should go back with looking at the projections and then, looking at it. Now, what is the very, very good thing about palliative care? I think this is what is the core. You tell people, excuse me, this is not focusing only on cure, but also on the care perspective. There are lesser equipments. With the number of interventions we do is lesser. The number of resources we use is less. It's very cost effective and sustainable. You can have cross-sectional projects, one for rich, one for poor. It's a non-profit also. And comfort care is another aspect which we should look at. It's a very comfort care for all levels of people and different, diseases. I don't need to tell neurological diseases and all. This becomes a very, because we do early intervention of and symptom control, the complications and all that becomes very less. So from the person's point of view, patient's point of view also, it is very cost effective because I'm doing early intervention. I don't need the patient go into a diabetic coma or a gangrene and a DVT. Because I'm doing early intervention, I'm able to prevent the unwanted cost or ICU which is required when you ignore those symptoms. So these are the things which we have to do. Long term also, there might be an income if you're going to have a rehabilitation and things like that. So palliative care can also be looked at a research, education, medicine model, which could be a very futuristic goal. It can have a holistic center, integrated wellness with this. It can become an exclusive center in terms of, showing a very different model, not just looking at death and dying and pain and all that, but overall look at it as a very human, compassionate, or humanity based, specialized care. That is what it is. So I would like to, say that all of us would love a very wonderful meal. This is the famous banana leaf with everything. In the South, it is very famous. But always let us remember, this is all fine. My stomach is filled. I'm very happy. But when I go or when I finish, I always need that dessert. And that dessert is what we all talk as salaries and profit. So let us not feel guilty for asking money. It is that extra bit for encouraging me, my team, and involve more medical fraternity into the palliative care system. And many a times we don't get opportunities to train the people or whatever it is because we don't have that model. Although we've evolved a great way, we've still not reached that there is one place where I can send the students and get them trained and things like that to increase the manpower. So that is very important. So unless we have a model which is needed by the society, we will not be able to reach out to more people. People will keep opting because of insurance. They will jump into corporate hospitals because they don't want to take free. They want to pay, but they have insurance. So they land up in corporate hospitals. Then they realize, okay, this does not have palliative care. So instead of that, if we can integrate it early into the system, I'm sure we can touch more patients at different level and understand their needs and definitely do the correctables and give them the quality life, which is the key for palliative care. Thank you so much for this opportunity. As RMD has started now since 2005, we have been able to show the models in different way. People have accepted. Now, you might have a fear whether people will accept. People have accepted that, yes, these services can be charged. Home care can be charged. Extra facilities like lab and pharmacy can be charged. Transportation can be charged. So there is not much of apprehension. Most of the time, because we have been trained that, or the models we've seen is non-for-profit, we think that is only the model which we need to adapt. But we have realized non-profit organizations who do not get funds beyond a point, everything is available, vehicle, but to give the salaries, we won't have money. So to avoid this system, I think if we have, the cake and eat it too, we can definitely make a successful model. Thank you for this opportunity. Thank you, especially Dr. Anjum, to give this wonderful platform to showcase what we have been doing. And any doubts, please feel free to contact me. Thank you so much.
Thank you, Dr. Republica. And I'm not sure about the time. I know we've crossed the 9 o'clock limit, but I hope there are some questions. And before I hand over to Dr. Suresh, I just wanted to say, I think we've got such a broad perspective. And even though, there was from the corporate, from the public side, from the government, and from the, charitable things, there were some very common threads. And I like, a few kind of terms and statements that palliative care is low tech but high touch. And even though you need the skills of being competent, being compassionate, and being committed, you still need to advocate, use the public media, get public awareness, train the doctors, build a network of not only professionals but all the people who can work with you, and don't feel shy to ask for money, because you need it and money is available, though you need to do some homework to figure out exactly where you need your money. And also remember, if you're working in a current setting, recognize the strengths and the weaknesses of that setting, and what you're already working with, so that you're not surprised, and you're not disturbing or expecting something that's not really going to work. So thank you again for those common threads, and I'm going to ask Dr. Suresh to add a few words and see if there are any questions that can be answered.
Yeah, again, Dr. Maya, I don't know how much time, is this the last session? Or is anybody waiting to?
This is the last.
No, this
Last
is
session.
Maybe we can afford to take a few minutes, I suppose, maybe because everybody is waiting to. So I have basically I have a question for Maliga, because see, you explained if I remember correctly, you have also been running a home care program along with the
Yes.
So because that has not been covered by any of the other speakers, basically, where does it fit in? What sort of patient do you see? What sort of patient do you suggest that be seen in home care? And what is the role of a home care program attached to a palliative care institution? Because that many people may be interested in knowing about that.
Yes, yes. So when patients come, of course we see them, but home care, definitely the patients, some of them are not able to come. They're just bedridden, and many of the, sadly, most of references come late. So when they cannot come to the hospital, and or sometimes you see the buildings, they'll say they cannot come from there, they can't even be shifted easily. So those kind of patients, we have a certain protocol where we first ask the relative to come with the medical background and everything, and make sure that, okay, these are the needs and this is why we are doing the visit. So we have a definite thing for that, and we arrange it in such a way. So we have, it is like just extending our service. So, and this is also no charge. So mainly it is because of that, because they cannot come, or the transport is not there, there's nobody to bring them across. So I remember all these things which used to happen in Kerala when we were doing the training. Even the approach is not possible sometimes. So such patients, we definitely go and see them. And you see, we want to promote more and more of home care, because patients are more comfortable that way. Reduces the hospital costs. For them, it reduces travel costs and so many things. And many patients are not affordable at all. So that's our indication of that.
Maybe we need to check whether there are any questions by the audience or some in the chat box. Anything is coming up, and so that.
There was one question: how do we start integrating volunteers in the new setup? So any one of y'all, I think it was directed towards Dr. Malika after her talk, but any of y'all can answer that. How do we get volunteers into the setup?
Yeah, so one is, when we keep doing this care, somebody or the other in the family, a family member, or they come to hear about it, and then they offer their services. Or we have a Facebook also, I'm sure other organizations also we have. So sometimes, when we just put it in the Facebook, people are kind of initiated, and they want to join. We also make sure why they want to join. So we have a format which they should come and really fill up, and tell us why they want, because sometimes somebody is lost in the family, and they just, because of that, they want to do, and then they want to go away from it. They may not be mentally prepared, because we give a volunteers training also. We do about 16 hours training for them. So that's more by hearsay they come. And of course, we can always ask for them in our Facebook and the social media. So that's how they just come. As your practice goes on, definitely there are other people observing you, the family members, the other, and even till today they will say, we want to come and work with you.
Can I add a little bit to what Dr. Malika
Yes,
has
please,
said?
please.
Dr. Suresh, sir, for home care, what we do it is a slightly different way, because we need to send our patients back home, and they come from all over India. So as I said earlier, that networking has been a very important part of it. We started a WhatsApp group specifically for sending patients home to peripheral areas, and we included all the certificate course people, all those who had done the IAPC certificate course, whether doctors or nurses, and from all. What I'm talking about is what we did in the north for all the 5 states, Punjab, Haryana, Uttarakhand, Delhi, Chandigarh, we included everybody. And whenever we had to send a patient home, we would ask, this is the address of the patient. Is there somebody who will look after him? And somebody would raise their hand and say, okay, I will take care. So we would send the basic medical documents and connect them to the families, and send a list of basic medication. We would make a little pack of medication and send them home, and connect them to the carer or the person in the village who would be able to take care, some local nurse, some local RMP who would be agreeable to come and look after them at the end of life. Some of them are fearful of using these medications, sedatives and opioids, when they're not used to it, but then we take the responsibility. We give them the prescriptions, and we give instructions in the local language, and we connect them to the families. And it has been a very successful model till now. I think almost 300 patients we've taken care of in this way. Another thing about volunteer training is that we do a lot of talking within the community. We go out and talk to the school children, to the college students, to communities through Lions Club, Rotary Club. For us, we have our Wives Welfare Association, for Army as well as for BSF. And schools and colleges, generally anybody who would like to host a program. So generally talking gets a few people interested. And then, as Dr. Malika has said, there's a volunteer training program now being run by IAPC also. I believe there's one at IPM. So many different organizations are doing it. And we just generally tailor it to the age group. If it is a retired person's group, we generally do different activities. If it is students, they would do different kinds of volunteer support activities. So that's how we plan to take it ahead. Anything you would like to add, Dr.?
Yeah, so that is actually like the effective use of social media for networking, particularly for practical involvement of people in the community. I think that's a great idea, because there may be somebody somewhere who's trained and who's and the patient nearby, and even you send them. Yeah, I think that's really, really wonderful.
Now the IAPC website also has state-wise list of directories of trained people as well as palliative care centers. So anybody who needs care can just look it up, and also take help from the centers for training volunteers in their own areas.
That is true. So with regard to me, we are doing it in 2 different levels. One is urban areas. Yes, we go and look after patients. In the community level, we involve the self-help groups, and there is one thing called Nalaval with it up, which is in the in the villages. They are actually young youth, so we train them and they become the volunteers so that they can reach out. And every weekly, twice when we go, they will accompany us or they will reach out to us. So we have a tab in which the particular village, that particular volunteer will give us a heads up, you need to come and visit this patient as an emergency or something. That is in the rural area. In the urban area, we have divided north and south of Chennai. And since we have 3 different facilities, from that facilities, people will go and do, home care. As Dr. Malika said, mostly it will be for people who are bedridden or can't, travel or something like that. And particularly, patients, because I do more cancer and non-cancer also. So we also have neurological patients whom we have to regularly go visit. So this is the way we do it. In terms of volunteering, I think it varies. We are very strong with the social work students actually. Different colleges are very sensitive about palliative care training and all that. They actually do wonderful work in terms of taking surveys. Because they are fit enough to do work in the urban and the rural area. So we have at least 6 colleges whom we regularly have the students. So they become a very core group for us to become a mediator between the organization and the community at all levels.
Yeah, thank you.
Thank you.
Sir, is there any other question in the box? Otherwise, I think maybe we need to bind it.
Sir, I wanted to ask one question from any of the speakers. How can we justify the long-term bed occupancy in palliative care? Like in a setup where I work, sometimes the bed space becomes a crunch. So we have to admit patients, generally we have to discharge them very quickly, but generally this is not for palliative care. We don't have a home care setup and we don't have hospice facilities here in Varanasi and around places. So how do we go about with this?
So who would like to respond?
Yeah, I like to answer that.
Malay.
Because this is a very often faced issue in the hospital. Definitely, people will ask for long-term care, and being a hospital, see, those who are admitted, if they can afford, they may have to pay the hospital. If they cannot afford totally, long-term care, it may not be sustainable. This is where networking comes in, and this is where we have to be complementary to each other. Everybody cannot do all the services. So we refer to the Dr. Republica's place, a hospice, or the other cancer institute has come up with a big another similar place in which is totally charitable, the hospice, very long term. So this is where you have to look for. We have networking. Our society, we have done this mapping of these areas. So we may have to refer them sometimes.
I think networking really helps. In fact,
hospital.
Yeah. Because 2-3 of the patients where, Dr. Mallika did all the acute management and the long-term care was referred to the hospice, which we are running. In fact, I think one girl is that tsunami affected girl whom we can never forget, who was, referred from Kadalur. From Kadalur, she was referred to Dr. Mallika, then with Dr. Rajagopal Singh. Then from there, then after she did all the pain management, because of long-term care, she was shifted to our hospice. She lived with us for 3 months, although she was very acute. She had a sarcoma, if I'm right. And she wanted mean korambu, which is a fish gravy. That's what was her last wish. And I think her brother has got a job. We networked with the Rotary Club. He's working in a private center. We made him study till 12th standard, and that's still going. So networking definitely helps.
Thank you, ma'am.
Are there any more questions? Or I think Dr. Suresh, we should, you want to close?
Yeah, if there are no other questions, maybe we are already 20 minutes past the allotted time. Maybe we can wind up if there are no questions. Dr. Nimisha, is there any other question in the chat box? Or?
No, sir. No, okay, sir. There was no. There's no other question. Okay. Thank you.
Thank you so much.
So big thank you to all three of you.
Thank you so much. Thank you.
Thank
you, Dr.
Maya.
Nice talk by all of you.
Very much.
So much. Yeah, thank you so much, Maya ma'am.
Thank you. Thank you.
Thank you, Dr. Maya, Dr. Suresh. Wonderful to have you.
Thank you so much. Thank you so much.
Thank you.
Thank you. Thank you. Thank you.